Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. Unfortunately, still some of you ask for some clips and topics that already is in the channel. Just go to the video or playlist and looking for that, you will find it. Here are those some topics that are related to this topic for today. Now let's do it. The size of the IVC and the change of its size during respiration, it gives us a lot of important information about the hemodynamic of the patient, especially right atrial pressure and central venous pressure. And almost in all echo study, the evaluation and measurement of the IVC is and changes in due to respiration is mandatory. Before that, let's go first look at very shortly on the anatomy of the IVC. As you know, except in situs inversus and great venous anomaly, in the normal situation, IVC is almost at the midline next to the aorta, IVC at the right side and aorta at the left side. And they are very close to each other. This schematic a little make distance, but usually they are contact next to each other. And except that the proximal, that entrance to the above the diaphragm, entrance to the right atrium, that up to the hepatic vein branches, IVC is more anterior compared to the aorta. So IVC is anterior to the aorta. This concept help us to do scanning both of them in one view. That later I am going to talk about that. Just remember that anterior to the IVC and aorta, we have liver that is give us a very good windows, ultrasonic windows, because there is not any gas around that is area, and liver is a good acoustic window. But remember that below the liver, at this level, left lobe of the liver, we have stomach, as you can see below the here, and colon transfers pass through this area. So we have those two structures that are usually full of the gas, and in some cases we have hard time to get acoustic window at the midline. Otherwise, in most cases, midline, because of the liver, we have good acoustic window. Now let's see how we scan IVC. This position for the scanning of the IVC is a supine with bending up the patient's knees. It may relax the rectus muscle of the abdomen, and so is better to maneuver and press, because with contracting it attenuate the ultrasound sound beam. So then after that we put our probe at the midline right below xiphoid process. Here you can see xiphoid process. We have costal margin here. You can feel it, costal margin with the tip of your. If you go to the end, it will be your xiphoid process. Like before the xiphoid process, put perpendicular your probe perpendicular to the skin marker to almost 12 o'clock, and a little fan up 10 to 20 degree or 30 degree depending of the patient body habitus. Then right away you can see one of those great vessel, IVC or aorta. If with this maneuver you didn't see any of those vessels, with just a little fanning right and left of patient, very gentle, 1-2 millimeter or maximum centimeter fanning to the left or right patient, almost always you can see one of those vessels. If it didn't help you, is gas and stomach and colon doesn't give you good acoustic window, ask the patient breathe in if the patient is alert. In that case, the diaphragm push everything down, stomach and colon and liver. In that case, over 90% of the or 90% of the cases, you can see at least proximal of the IVC or aorta at that level. If it doesn't help that way, I'm going to talk about the off-axis view IVC shortly. In those, then we will see our one of those vessels. Let's see how we differentiated IVC and aorta from each other in the ultrasound. Here we have cross-sectional ultrasound of the IVC. In the echo mode that we're doing in the echo, the sound beam or sector pass through this line, and the machine creates a cross section of the that area, and it looks like we are watching from the left side of the patient to the right side of the cross section surface. And finally, machine flip it up and twist it clockwise, our sector, and flip it posterior. Finally, it gives us this image or clip. As you can see, this side is marker side, is our cephalic spot, and the other side, this one here, is a caudal or toward the foot of the patient. Here cephalic and caudal. Here anterior and posterior of our image and patient. As you can see here, we have a right ventricle, this area, right atrium, tricuspid with a little show up here. And as you can imagine, you can assume here, when our sector passes through exactly here, usually most of the time we will see middle hepatic vein, as you can see here on here too. So if we put it exactly at midline of the body, usually we see both of them together. If not, just we have to a little fan, millimeter fan to the left or right. Finally, middle hepatic vein show up too. On the vascular and abdomen mode that they do in the abdomen or vascular study, the cross-section surface, it looks like we are cutting that cross-section surface and watching from the right side of the patient to the left part, and machine twist it counterclockwise up and flap it up, and finally it gives us this image. As you can see here on the abdomen and vascular study, here will be cephalic part because marker is on the left side. Here cephalic, and here is caudal part, and anterior and posterior the same way. We have right ventricle, right atrium, IVC, middle hepatic vein. Maybe in some cases, many cases, you will see posterior to the IVC there is another structure, is vascular. This is most of the time, almost always, this is a mirror image of the proximal part. You can see the color, everything is the same, the size almost the same. So this is mirror image. Don't confuse with another structure or any abnormality. When for the measuring IVC, we have to make it as much as possible IVC horizontal on the monitor. In other words, we want to try to sound beam direction be perpendicular to the both wall because we are going to increase resolution, axial resolution, and our measurement become more accurate and more sensitive. So for that purpose, we can just with a rocking maneuver here, just a little on this. For example, if you want to make it this IVC more horizontal, we have to put push or angle handle of the probe toward the head or tip of the probe toward the foot, angling toward the foot, then it become more horizontal. For color Doppler is opposite way. We want to make as much as possible our vessel become as much as possible parallel to the sound beam. So for each study, for 2D measurement, you have to make it parallel IVC, And for color Doppler, doesn't matter, IVC or middle hepatic, you want to make it as much as possible parallel. So with just rocking or heel towing, you can get to this purpose very easy. For differentiation of the IVC and aorta when we are scanning, there are many technique and tips that I'm going to give you. First of all, when you start putting your probe at the midline, when you see the first vessel, you have to ask yourself, okay, if the vessel has the aortic characteristic or not. The aorta, as you can see here from IVC to the aorta is pulsation, first of all. Second, the size is all the way is constant and equal, doesn't change during respiration and cardiac activity. And the third has a wall thicker wall, and the last one has positive shift. As you can see, blood goes toward here and positive shift. IVC opposite way. First of all, usually doesn't have wall thick. On this case, no, this one has it a little thick IVC wall. Second, usually the size of the IVC, along the IVC, the size of the IVC is not even. The change, especially with the respiration and cardiac activity, unless the patient has high right atrial pressure. In that case, that you can see on this case, it doesn't change too much. Another one here, as you see colored on this one, is negative shift. Blood goes this way, goes to the heart. So, and another one is connection of the vessel to the right atrium. Aorta doesn't connect to the right atrium, goes all the way up. So, and the last one, you can see middle hepatic or one of the hepatic vein connected to the IVC. Aorta doesn't have branches that you can see, only two branches at the distal. At this level, you can see this one, celiac and superior mesenteric artery. All those features can differentiate IVC and aorta from each other. For the last tip that you can use, it is very easy, but usually here, when you put it, the first vessel, you saw it on the monitor. If imagine still you are not sure because of the body habitus, anatomy of the patient, you cannot see right atrium very well, you don't see hepatic vein, all those stuff, still you are not sure, is very easy. When you see the first vessel with fanning left and right, fan from the left of patient. If after fanning left of patient you see another vessel, so it makes sense that okay, the first one was IVC, because when you fan it to the left side, you pass that one and you see another vessel, so the second one will be aorta and the first one will be IVC, or vice versa. If you scan, you fan it, you see the first vessel and you fan to the left side and disappear, you don't see any vessel, so most probably that one, first one, was aorta. Just fan to the right of the patient, you can see the next vessel that will be IVC. With all those features, you can get any of them and differentiate those two from each other. One more thing I have to mention, if you want to see more distal of the IVC, just angle your tip of the probe toward the foot of the patient, or with towing of the probe, you can see more distal of the any vessel, IVC or aorta. For measuring IVC diameter, first we have to make sure we have a good image. A good image has that all the way IVC is open and is a largest diameter. How we can make sure that? If it's not open all the way, just twist a little clockwise or counterclockwise, whatever that help you, and open it. When it's open, slowly fan to the left and right, very small. Then when you saw the largest diameter, at that moment is your image, and then acquire, and then freeze it, then go cine loop back and forth and find the largest diameter of the IVC. In this technique, based on the ASC, the spot we measure should be half centimeter to 3 centimeter far from the entrance or connection of the IVC to the right atrium. Any spot from that and our measurement should be perpendicular to the IVC. Don't forget, not perpendicular to the monitor, perpendicular to the IVC wall. For example, if imagine this is small, here is 3 centimeter. I'm just suggesting. You want to measure this spot, you have to measure this way, not this way, perpendicular to both wall. The best spot based on some research is 3 to 4 centimeter far from the entrance, or any spot at that area from 5 centimeter to that is largest one. We go and measure that spot. Another technique is using M modes. So we make it good images, then we put cursor, make sure the cursor perpendicular here, perpendicular to the both wall, then we go on the M mode, measure the largest spot that we can see. That is our measurement for IVC. The normal IVC should be equal or less than 2.1 centimeter. After measurement IVC diameter, we have to evaluate IVC respiratory variation. For that purpose, we have two techniques, 2D and M mode. On 2D, when we have good images, we ask the patient breathe in all the way in and breathe out all the way, and then acquire our clips for both of those time, then freeze it. Then we go back and forth. We see during inspiration smallest one, and during expiration or exhale largest one, the same spot, we measure it. Usually this technique is very hard to find it just because you are judging based on your eye, and so it will not be too much accurate. Beside of that, with deep breathing in and out, usually we lose the view, so it can be move a little left and right, so our measurement will not be too much accurate. The best technique for respiratory variation of IVC is a sniff test on M mode. For that purpose, we get it good image, then we put cursor perpendicular that spot that we are supposed to measure it, 3 to 5 centimeter far from the orifice. Then when we have good image, we ask the patient breathe very fast and one time through the her or his nose, or sniffing one time. In that case, we will have a good modes that open and close. You can see become smaller and larger. Here, then we go measure any spot next to each other, smallest diameter and largest diameter. The smallest diameter is right after sniffing, and largest before that. That will be our respiratory variation of IVC. If this amount of the chase is more than 50%, we call normal collapsibility. If it's less than, is positive, a sign for increasing right atrial pressure, that I'm going to talk about exactly how much and what. For example, if we measure at the largest be 2 centimeter and the smallest one be 1 centimeter, so collapsibility is 50%. If it was 2, now become smallest become less than 0.25 centimeter, so collapsibility is over 75%. As you know, many patients, especially in ICU, or those have COPD or bloating abdomen, and their abdomen is full, or the patient maybe had abdominal surgery, all bandage or ventilator. In those cases, subcostal window will not be successful, and we cannot get IVC. In those cases, we can use intercostal window. For that purpose, it's better we turn, if we can, turn the patient a little left lateral oblique decubitus. If not, that's fine. We go put it our probe below the nipple, one or two intercostal, almost between 6, 7, doesn't matter, as long as you can see the liver as a acoustic window. When you see the window acoustic, then hold the marker toward the head of the patient and point to the medial of the patient. So in that case, your probe should be here or from here, doesn't matter, any spot that you can see the liver. Then you point your probe toward the mid center of the patient, almost this angle. When in that case, just with fanning to your left or right, suddenly you can see usually very easy IVC, and most of the time at this window you can see aorta the same way, because as you can see here, our sector passed through this line. So you can see the first one will be IVC and the second will be aortic artery. In many researchers, it has been shown that there is a good correlation and relationship between the size of the IVC and collapsibility and amount of the right atrial pressure. And if we use those two parameters, over 90% our measurement for right atrial pressure will be accurate. There are a little controversy among the researchers that which number we use, but based on the American Society of Echocardiography, we can divide those findings in three categories. First, in those situations that IVC is equal or less than 2.1 centimeter and IVC collapsibility is over 50%. In that situation, right atrial pressure will be normal around 3 millimercury. It can be from 0 to 5, still in normal category. In another category are those patients that IVC is dilated more than 2.1 centimeter and collapse less than 50%. In those conditions, the right atrial pressure will be 15. Any other situation between those two goes to this category that right atrial pressure become 8. For example, if IVC is not dilated, is less than 2.1, but collapsibility is less than 50%, it goes to this category, or vice versa. In evaluation of right atrial pressure with this technique, we have to remember some important other parameters. For example, when we have right ventricular diastolic dysfunction, especially if we have restrictive diastolic dysfunction of right ventricle, we have to use the upper limit. For example, if a patient has this parameter, but E to E prime is more than 6, and TAE index of right ventricle is less than 50 to 55%, so we have to use upper grade of our limitation. Or, for example, here, if the patient IVC is huge, dilated over 3 centimeter, and is almost doesn't collapse, is less than 20%, in that situation, we have to use 20 millimercury, and so on. Besides of that, in those cases that the patient cannot have sniff tests or cannot deep breathe in and breathe out, for example, patient on coma or unconsciousness. In those cases, we have to take the collapsibility 20%. If his collapsibility is less than 20%, we have to go with the 8 centimeter, we will, or 8 millimeter, sorry, 8 millimeter, or here we have to use 20, or here we have to use 5. In another one is in young athletic people. We can expect to see normally IVC be dilated, but in that case, collapsibility will be normal and more than 50%. But there are at least one report that a young lady everything was normal, but IVC was dilated and collapsibility was less than 50%, and there wasn't any other finding. All echo study and CT scan, MRI, everything was normal. So we have to be cautious about using this parameter. And the last one is collapsibility will not be accurate and sensitive in those patients that are connected to the ventilator. For a middle hepatic vein Doppler, as a general rule, is better when we do IVC, we check and do Doppler on hepatic vein. As you can see here, hepatic vein, usually middle hepatic vein is anterior to the IVC, and most of the time when we scan IVC, if we little fan left and right when you see IVC, middle hepatic vein usually show up, but it doesn't matter. Any of those hepatic vein that can give us clear image and we can do Doppler will be okay. For that purpose, we put it sample volume almost 1 centimeter before connecting to the IVC, and we make it as much as possible with Hilto, our sound beam, be parallel to the hepatic vein. Then we hit the pulse Doppler and it give us the middle hepatic vein. Middle hepatic vein give us a lot of information, especially in those cases with pulmonary hypertension, the severity of tricuspid regurgitation, and even right atrial pressure measurement. For more information all about the middle hepatic vein Doppler and interpretation and all finding in many situations, you can go these 3 topics I have in channel. You can check them out. We are done. Up to the next time. Have a wonderful time.